Hi, everyone, and welcome to this new session of the Tuesday lunch with Rita. Today we have an amazing session on the VEXAS syndrome, and I'm delighted to introduce the chair of the session, who is Dr. Sara Bindoli from Padova University, Italy, who's a rheumatologist and expert in all these rare disease, very interested in VEXAS, and she will introduce the speaker, and I will help her at the end for the Q&A session. So, Sara, thank you very much for coming to chair this session.
Thank you very much to you, Alexander. It's a pleasure to be here and speaking of VEXAS syndrome, very hot topic. So it's my pleasure to introduce our two speakers of today, both very expert on this complex syndrome. So first, I'd like to introduce Professor Sinisa SAVIC. Professor SAVIC is Professor of Clinical Immunology and Honorary Consultant Immunologist at the University of Leeds and St. James University Hospital in UK. He has long-standing clinical and research interests in the molecular and genetic basis of many autoinflammatory disease and, of course, their treatment. So he will deliver a talk about the discovery, genetic, and pathophysiology of VEXAS, as well as treatment options. And then our second panelist is another distinguished professor dedicated to the study of VEXAS and many other autoinflammatory conditions. It's a great pleasure that I introduce Professor Sophie GEORGIN-LAVIALLE. Professor Georgin, she's professor of internal medicine at Sorbonne University in Paris, and she currently works in internal medicine department at Tenon Hospital, and she's the chief of the autoinflammatory clinic. So she will deliver a talk about the clinical manifestation of VEXAS and what is true and false in VEXAS. So after this introduction, I think we are ready to start. The virtual stage is yours, Professor. So please, the first speaker is Sinisa SAVIC. So thank you, Professor.
Thank you for the kind introduction and for invitation. I'll share my slides. I hope that's now okay. As I said, thank you for inviting me to speak. I'm delighted to speak on this subject. It's one of my favorite topics, VEXAS syndrome. So I will, for the first part, I'll talk a little bit about genetic discovery and some of the pathophysiology of VEXAS. We only have 10 minutes, so it's not necessarily going to be in depth, but I'm going to give you some main features. So this is a sort of picture which I hope many of you by now are familiar. That the condition was discovered in late 2019, early 2020, and since then there's been an explosion of interest and papers and work. Fascinating disorder, and Sophie is going to talk more in detail about the clinical manifestations of VEXAS syndrome, but just as an introduction, just what VEXAS really stands for and what the main features are. And the acronym stands for vacuoles, which are found in myeloid and erythroid precursors in the bone marrow. And this is one of the features that you can see on the bone marrow biopsy and on the picture there on the right. E1 enzyme is the target protein that's mutated in this condition and is coded by the gene called ER1. X-linked is because the gene itself is found the X-linked chromosome. Autoinflammatory because many of the clinical features are consistent with what we would consider to be an autoinflammatory disorder. For example, unexplained fevers, weight loss, constitutional symptoms, skin manifestations, and so on. And somatic because actually, as we will come to discover, the condition is caused not necessarily by inherited, but mutations which have been occurred within the bone marrow itself. So the picture in the middle shows widespread clinical manifestations of the condition, and essentially any body organ system can be involved. But the condition is divided into rheumatological or inflammatory manifestations and conditions that overlaps with, and also includes progressive bone marrow failure and in some cases frank myelodysplastic syndromes. And I will leave further details about this with Sophie to talk about. But so another fascinating feature of VEXAS syndrome was its discovery, and it was done by David Beck in NIH, and they had access to this brilliant cohort of that they've collected over the years. They had just over 2,500 people for whom they didn't have a genetic diagnosis, and this was in their program of discovery. And they essentially devised an algorithm whereby they looked at genes that were involved with ubiquitination, and this is because a number of other autoinflammatory conditions do have ubiquitination as an important part of its pathophysiology. In essence, by filtering in this manner, they discovered 3 unrelated patients, all male, who appeared to have a heterozygous mutation in a gene called UBA1, and all had the mutation at exactly the same position, which is this methionine 41, although the amino acids were slightly different. But what was quite obvious at the time when this was discovered, given that this is an X-linked gene and these were male patients, the fact that this mutation appeared to be heterozygote suggested that this wasn't necessarily a germline mutation, but something that was acquired. And indeed, when the investigations were done using from the bone marrow, what was then found is that the mutation had arisen within the bone marrow progenitors, and it was present pretty much in all the myeloid and erythroid lineages, but the difference being that only the myeloid cells were able to survive in the periphery. So although the mutation was present in lymphoid progenitors, for example, within the bone marrow, the lymphocytes within the periphery did not carry the mutations, only the lymphocytes which carry the wild type variant survived, whilst on the other hand, in lineage, it is the largely neutrophils and monocytes that carried mutated form of the UBA1 that survived and were in the periphery, and as it will become, were responsible really for many of the inflammatory manifestations that occur in the condition. So why is this methionine so critical? Well, it's largely because this is an initiation site for protein translation for the UBA1. So the UBA1 has 2 isoforms, UBA1A, which is nuclear isoform, and UBA1B, which is the cytoplasmic isoform, and the one that has critical E1 ubiquitin function. And if you mutate the position methionine 41, you essentially lose expression of UBA1B. So this isoform is no longer expressed. And in essence, you have loss of function, loss of expression of UBA1B in mutations that affect the methionine 41 position. And these are so-called canonical mutations that we have now come to understand as the main variants, mutations that really cause VEXAS syndrome, and they have 100% pretty much phenotype-genotype correlation. And the UBA1 is critical for this quite essential biological process called ubiquitination. UBA1 E1 enzyme is the first enzyme in the ubiquitination pathway. So without it, really the whole pathway falls apart. And there is no alternative enzymes present in humans that can account for the loss of function of the UBA1. And there are many biological processes that are controlled through the ubiquitination, including inflammatory signaling and many immune signaling pathways. So unsurprisingly, I'm not going to go necessarily in huge details about that, but I think most illustrative way in which you can see how the ubiquitination can affect functioning of some of the cells that are critical for mediating symptoms and signs in VEXAS syndrome is this picture where it shows the healthy controlled neutrophil and the neutrophil that you see in the VEXAS syndrome. And you can see that this cell is completely disorganized and abnormal looking. And if you look within this cell, there are many inflammatory pathways that are activated. So unlike some of the other autoinflammatory syndromes where we may have 1 or 2 specific pathways that are critical for this pathogenesis manifestation, in VEXAS what we find that many inflammatory signals are elevated, and as a result many inflammatory cytokines are elevated. And as I will come to talk about this later on, treatment of VEXAS is therefore complicated, and no one single targeted therapy is therefore likely to be helpful. Since the original discovery of VEXAS and finding that the methionine 41 is the main target site for the mutation in the condition, further additional sites mutated in the gene have been discovered, and this was one of the sites that was discovered subsequently shortly after the discovery of VEXAS, and this was discovered with my research in Leeds. And we found this other mutation in a position serine56, which essentially, again, it segregates to myeloid as you would expect with other methionine 41 mutations. But what this mutation does, unlike the methionine 41, it does not cause loss of UBA1B expression, but it causes of enzyme function, and it's temperature dependent. And interestingly, because of this, the phenotype that you see with serine56 is somewhat different to what we have come accustomed to see with classical VEXAS. So these patients have more predominantly hematological manifestations. They present with more myelodysplastic-like clinical picture, more profound cytopenias, including anemia, low platelets and neutrophils, and they have a more pronounced bone marrow dysfunction, and they don't have as many inflammatory features. And other mutations, again, which are not found within the methionine 41 position, have been described again by a group from France here in adenylation domain, producing similar kind of less inflammatory but more bone marrow failure type picture that we have seen in some patients. And we have done further work, and there's been other groups that have also looked at across a large group of myelodysplastic and patients with myeloid conditions where we suspected that UBA1 may be important in the disease pathogenesis, and this is something that we have recently been working on. And we have picked up a number of non-methionine 41 variants across various myeloid conditions, mainly myelodysplastic syndrome, but also acute myeloid leukemia and others. And as you can see, some of these variants have more than one patient affected, and they segregate quite nicely with this group of conditions. And there are other works which have shown that these variants do indeed have an enzyme function, so they don't lead necessarily to loss of the UBA1 expression, but certainly lead to reduction in UBA1 activity, and therefore have some contributory role in terms of developing some of these more myeloid type conditions. And to finish off this part of the talk, this is now recommendations on how we should be screening for the UBA1. This work is currently under review, but this is a work that was done by the international expert group, which came up with a number of consensus agreements in terms of how to screen for VEXAS, how to manage it, and so on. So this is one of the recommendations in terms of how we should conduct genetic testing for VEXAS syndrome. And the group was mindful of the fact that obviously VEXAS syndrome will present across a variety of healthcare systems, some which have better provisions, some which have less well equipped laboratories. But what was agreed is that probably the simplest way of screening for VEXAS syndrome, at least for these canonical mutations, could be done by Sanger sequencing if you just include a couple of hotspots mutation on exon 3. This is sufficient because most of the mutations that have been shown in VEXAS have relatively high VAF, even at the presentation. VAF stands for allele frequency. So even with the Sanger sequencing, you can pick up somatic mutations which may be down to 5 to 10% relatively with confidence. However, of course, ideally, you might want to do this screening using other methods which allow you to higher resolution, So for example, digital droplet PCR is another way of screening for it, or ideally maybe targeted next generation sequencing, which could cover the whole gene, particularly now that there are other mutations within the UBA1 gene that might be of interest and which are outside the exon 3. And also targeted next generation sequencing is valuable because many of these patients may have additional mutations in myeloid panel, particularly those who present with more of a hematological picture and myelodysplastic like syndrome. So these are current recommendations, and these may change as more and more about the VEXAS syndrome. But as I say, it was mindful. These recommendations were mindful of the resource restrictions that may exist in some places, and with ideas that how we should ideally be looking for novel mutations in VEXAS syndrome. So I will leave it there for this part of the talk, and we'll hand over to Sophie to talk about the clinical manifestations of VEXAS. So I will stop sharing my content and I will hand over to Sophie.
We don't see Sophie right now. She was connected at the beginning. So, Sophie, can you join us? Yes, she is.
I'm there. It's just a little bit long. So can you see my screen well?
Yes, perfect. Thank you.
Okay. So I will speak for 10 minutes, and I want to share with you the clinical aspect of VEXAS syndrome. So in the past, before the discovery of the disease, we would see those patients like this. So they would be kind of most adults, sometimes elderly, and many, many faces, and we couldn't classify them. So thanks to the discovery, we can now classify them, because in the past we would have to classify between like what's the same clinical features are there, like this red people or yellow people, etc. First thing, the disease is totally cosmopolitan, so we have been describing cases in almost every continent. And this is the main picture. It's usually an elderly man, and the biological features are very important. We will see them with macrocytic anemia and elevation of CRP. And then we will see the main organs that are affected, and mainly the skin and general features. So for the biological features, I want you to remind that the CRP is almost always permanently elevated and very high. So that's a very important thing. And the curious thing is that the size of the red blood cells, the medium globular volume, is very elevated, and it's something, a clue that should let you think that it can be VEXAS. Then the vacuoles, we will, in the next true and false part, we will speak about vacuole, but I want you to look, especially, for example, Alexander Belot is a pediatrician. I don't know if he's very used to see vacuole every day. So look, Alexandre, here you can see that there are some vacuole in the myeloid progenitor of the bone marrow. Here you can see a lot of vacuole in the megakaryocyte, and here it's in the blood, and we can see vacuole here, vacuole here. So it's an important feature that we are looking for in VEXAS. Here now your eyes are very used, so you can see vacuoles everywhere on the slides. Then we will spend 2-3 minutes on the skin features, because they are very, very important. So here you can see a very elegant man who is more than 50 years old, and we will speak about cutaneous features. Here you can see some of them. They can be erythematous, but they can also be purple, and they can be in all the body, the front, the back, the arms, the legs, and also the neck. So when we look more, they can be erythematous. And here you can see that they are round. And I will make a zoom on the features. Here you can see them. It's another man, but they are almost the same when it's characteristic. They are what we call arciform. You can see here that they are round and they are like an arc. Here you can see the prototypic pathognomonic feature of VEXAS. It's a arciform lesion, which is erythematous, papular. And here are some other features that we can see, but this one is very pathognomonic. So if you see this in a man with CRP, you really have to look for VEXAS. When we perform biopsy of these features, we will find myeloid cell infiltration. There is no vasculitis. Here I show you on the largest skin cohorts, we can see again these arciform features. All of them are maculopapule. They are all over the world. And also, I will not show you some pictures, but people can also display livedo or pustule. So the spectrum is wide. Here you can see the very pathognomonic features. Here you can see on the back, in the neck, look here in the neck, and this man is not 70 years old. This man is about 55 years old. You can see them in the front of the body. Here, this man is a little bit older, but you can see the arciform lesions that are pathognomonic. And also, you can see two other features that are very important. First one is the ER chondritis, only 35% of patients, but very evocative if you see it. And here you can see erythema and edema around the eyes. We will see this just after. Also, when you look at this picture, you can guess that the man is very tired with the alteration of the general status. If some of you are following patients with dark skin, here is a patient from India, and you can see when the skin is dark, you can see that the lesions are erythematous, papulous, and sometimes they can be a little bit squamous. So we have spoken about skin, about general features and biological feature. Now we will talk slowly about pulmonary infiltrate, because in 2020 was the discovery of the disease, and it was also the COVID pandemic. And in this disease, there are a lot of pneumological features, and they can be taken for infectious such as COVID, and also VEXAS patients can also have COVID. So it's hard, but please, when you have a VEXAS patient, you should perform a CT scan to look for pulmonary lesions. Here you can see them with several aspects, and there are now several publications on the pneumological aspects. I will speak about the eye involvement, because it's very important in this disease, and it can also lead you to the diagnosis, to think of the diagnosis, because we don't have so many diseases, autoinflammatory disease with eye involvement, and the clinical features are very specific. So I will begin by a very important feature. This one is, you can say, oh, this is too much. She shows a very severe symptom, but I want you to remember to look at the eyes, and the patient will tell you they have an edema of the eye. It can be on one side and then on the other side. So this was a impressive form, but many patients can have this. So you should think about the disease when a patient has edema of the eye. Here you can see one which is a little bit less severe, but you can see also that it's only unilateral, and on the other day you can have the other eyes, which is severe. There are also some other features that I show you on the picture, and if you perform a scanner, you will see infiltration. And the same person had a pulmonary involvement, and now your eyes are very familiar with the vacuole. So this is a publication from Eduardo Martin-Nares from Mexico, an expert of VEXAS in Mexico. Here again, some picture of the eyes. Here you can see edema of the left, and here both eyes have edema, and the CT scan. Also, you can have abnormalities in the vitreum. And with CT scan, you can also see infiltration. So the eyes are very much involved, and it can be a big clue to think about VEXAS. What about arthritis? Maybe some of you are rheumatologists. So The polychondritis was in the first description, as Sinisa told you, but actually this is the results of our cohort, and now we have data on more than 300 VEXAS French patients, and we know that polychondritis stands only for about 1/3 of patients. I will show you a few pictures because if you have seen them, you will recognize this is ear chondritis and a patient with tracheal chondritis. Here again, and here you can see the ear chondritis and the tracheal chondritis. Also here you recognize again the lung because now you are aware that the lung can be sick in this disease, and also the ear with the chondritis here, which is very active, erythematous. This one is less active, and the pulmonary involvement is less active also because the patient received steroids. What about what else? So people can display venous thrombosis. Here you can see a pulmonary embolism, and the patient had the classical vacuole. I will speak a little bit about arthralgia. Only in 1/3 of patients, they can be only arthralgia, they can be also erosive. And here it's a case of sacroiliitis, quite rare, but it can exist. And here you can see the sacroiliitis, the skin involvement, and the chondritis in a patient with VEXAS. For those who are wondering if kidney involvement can exist, it's rare. Sometimes we can have nephropathy, like IgE nephropathy, and very rarely AA amyloidosis in this patient, for example. So here is again an involvement I wanted to show you with severe cutaneous feature, but also eye involvement. And in this patient, he had a severe infection. So I will go now to some mimics. If you have an elderly patient which you suspect lupus, I think you should really be careful about VEXAS because there are a few cases published that were mimicking lupus because of the cutaneous mucus involvement. But if you have elevated CRP, you have to check for VEXAS. Here is a presentation that was looking like Langerhans cell histiocytic lesion, but it was a VEXAS, so it's kind of tricky. And look at this eruption, it's very popular. And you recognize the eye involvement and also the arthritis. So this was edema, eye, pulmonary, and it was also VEXAS. Look at the vacuole here. In a few cases, you can also have muscular involvement with myositis. So to date, there is no obvious genotype-phenotype correlation. One word about the comparison with idiopathic recurrent polychondritis. In this case, it's mostly women without inflammation, whereas in VEXAS, when there's recurrent polychondritis, it's usually men with a lot of inflammation and pulmonary involvement and anemia. So all those data were confirmed in several cohorts worldwide, especially in the US, in France, in Spain, in Italy. We have Sara here with us today. So in Italy, they are very active in VEXAS with the same feature that are described. And there are also some very good literature review that I can advise you to read. This one from the NIH, which is very interesting with all the cutaneous features. I look again at the arciform lesions, the chondritis, the livedo, and the eye involvement. So I recommend you to read this very good review from Marcella Ferrada and David Beck. And they also proposed recently a nice review in JAMA Dermatol with all the drawing of the cutaneous involvement that you can see there. I really like this review, so I advise you. And again, here you can see the RC-form lesion. So I hope that now you remember this RC-form lesion. And so in conclusion, if you have a middle-male age with macrocytic anemia and inflammation, especially after 45 years old, you can suspect the disease, and you will check for the skin. And as Sinisa said, you will check for UBA1 mutation. So don't worry, maybe it's everywhere. Don't shut your eyes. Be aware of the disease. Never forget the eye involvement. And this is my summary of the main clinical features. Eye involvement, chondritis, elderly patient, very tired, the RC-form lesion, and check for vacuoles, and check the face. It can be multifacet with a wide clinical spectrum. And I thank you for your attention. That's it.
very much, Sophie. I think we can pass to the second presentation, the third, sorry, presentation on treatment.
I can, thank you, Sophie. Brilliant overview. I love some of the dermatology, skin manifestations. So I'll continue now just talking about the treatment of VEXAS. And I guess one thing that Sophie had mentioned briefly is that these patients do respond to corticosteroids. So corticosteroids are actually the only thing that we know for sure work fairly well in VEXAS. However, the use of corticosteroids in VEXAS is limited largely by its toxicity, really. And what we know about, the main point to make really is that we are still working out what's the best way to manage VEXAS. We still don't have internationally agreed consensus. We have quite a lot of anecdotal and retrospective studies, but not really any good long-term effective trials to really inform how to treat VEXAS. And this diagram here, which I put together with one of my clinical fellows, Adam Al-Hakim, is really just illustration of mostly of considerations in terms of how we should approach treatment of VEXAS rather than actually hardcore guideline in terms of what we should do. There are a few other slides, of course, with a similar sort of presentation that I will go through, but one point to make here is obviously we don't first of all have agreed diagnostic criteria for VEXAS. So this is one thing that's holding us back in terms of trying to set up some of the prospective trials. Also, we don't have any yet fully agreed criteria in terms of treatment response to VEXAS, and people have come up with various options to look into that, and I'll go through that later on. But currently, again, we don't have any validated treatment outcome measures for VEXAS syndrome, and that makes a lot of what we talk about in terms of treatment difficult. So the outcome, once you get VEXAS, people who have VEXAS syndrome some of them have disease course which is more aggressive. Some have disease course which is more indolent. However, right now we don't have good biomarkers to predict at the start of the presentation to know which patients are going to have a more aggressive disease course, which patients may do okay, and which cases we might have to treat more aggressively. There are some indications that maybe certain mutations, such as methionine 41 valine substitution, may be more aggressive and more severe disease cause than the other substitutions that happen this side, although this hasn't yet been confirmed in prospective cohort studies. So one thing which is lacking is basically having those markers at the disease outset to tell us who is likely to do well, who we should be treating more aggressively, and who we should be maybe concentrating in providing the supportive measures. So there are some potential treatments which are curative, and I will talk about the potential role for bone marrow transplant in these patients. But the problems currently that we have in this respect is that all the criteria that exist for bone marrow transplant selection are VEXAS specific. And a lot what we currently do is borrowed from treatment of myelodysplastic disorders such as myelodysplastic syndrome itself. And the criteria for selection of patients is not fully adjusted really for selecting patients with VEXAS syndrome. Nevertheless, despite all of that, quite a few patients have been transplanted and with some good results, and I'll talk about that in a minute. We also need to think about various supportive measures which are needed for treatment of VEXAS patients. So it's not just about necessarily suppressing the symptoms, suppressing the inflammation, and targeting the malignant clone, but many patients have other needs in terms of supportive treatment. And Sophie had mentioned, obviously, that this condition is associated with increased susceptibility to thromboembolic events and DVT and so on. So the place of anticoagulation has not been yet firmly understood. Should everybody be anticoagulated, or only patients who have experienced already some of the complications? And I will talk about that in a few slides. So there are a number of ways in which we can approach treatment of VEXAS. So for example, you can target the clone, and that can be achieved in two different ways. Obviously, allogeneic stem cell transplant is one way, which is potentially a curative treatment. And there are also treatments that have been used for myelodysplastic disorders, which may have similar effect in terms of targeting the clone, and I will give some examples of that. As I mentioned previously in my first part of the talk, VEXAS is associated not with one simple biological pathway that is activated, and therefore by targeting that pathway specifically, we can then achieve a desired goal. Whenever you measure cytokine profile in VEXAS patients, you will find that numerous different cytokine, pro-inflammatory cytokines are elevated. Many inflammatory pathways are activated, and therefore choosing the targeted treatment is difficult. There are, as I will come to talk to you, some evidence from the literature what may be valuable approaches, but it doesn't work in these treatments. These are traditional disease-modifying drugs such as cyclosporine, methotrexate, and so on. There is no good evidence that these treatments are all that helpful. Maybe they may provide some additive effect in combination with targeted biological therapies, but again, there is not huge amount of even retrospective to support it. And I mentioned already a need for supportive care. So, talking about the bone marrow transplant, so this is really probably the largest case series so far. This was published last year, and this is the multi-center retrospective analysis from European Bone Marrow Transplant Registry, and this is outcomes of 19 patients which have been transplanted over a number of years. In essence, what this shows is that overall survival at roughly 2 years is okay. It's about 75%, and total transplant-related mortality is there about 25%. As you can see from the table here, and Sophie mentioned that this is a condition of elderly men largely, this cohort is relatively younger to what is the average age of VEXAS presentation. So there are various cohort studies which have been published, which Sophie mentioned, and the average age is probably more 65 and over, but as you can see, the average age of this cohort is around late 50s, which is probably reflective of the fact that to qualify for the transplant, you do need to be of certain age, and obviously the younger patients are more likely to be able to withstand the requirements of the transplant treatment, which is insignificant. I mean, it's a quite difficult procedure to undertake. And in this cohort, actually, a lot of the patients also had overlapping MDS, which again was probably an additional reason for why these patients were transplanted. So moving on, in terms of other treatments that can be used to target the clone, the azacitidine is a treatment that is now becoming more and more talked about. There are a number of publications that I've chosen. I've been biased and I've chosen one from the UK, but there are a number of other reports which are out there of retrospective case series, and all of these have really shown very similar outcomes. Azacitidine is a medication which belongs to a group of drugs which has it's called the methylating agent. It affects the methylation of the DNA. How that actually works in terms of targeting the specific UBA1 clone is not entirely clear, but what it is clear is that when you give azacitidine over a number of cycles, you can achieve tapering, you can achieve control of inflammatory systems, and over time you can also this is associated with reduction in the clone that is detectable in the peripheral blood. So far, this treatment is showing promise. Again, not all patients respond, as we have learned. I mean, these are like all case series. These reports are biased, of course, to patients who do respond, but we do know of patients who don't respond necessarily to azacitidine. What more to say about azacitidine is important is that there is a relatively high burden of treatment because azacitidine needs to be given in hospital. It's an injection treatment. There are now oral preparations of azacitidine, but these are yet not widely available and they're highly expensive. And the treatment needs to be given over a number of cycles. Then moving on to other possibilities, and this is work that Sophie had led with the French network and so far the largest cohort study of outcomes that patients with VEXAS treatment, and they've looked at various targeted therapies that were given to the patients over a number of, and this is over 110 patients were treated and 194 targeted therapies were used. Clearly, some patients received more than one. I think what's striking, what the striking observation to me here is that even with the best responding treatment here, only a third of the patients ever really achieved a complete response. Now, again, something just to bear in mind, again, the complete response here was combination of three outcomes. That is, the inflammatory features needed to be under control, prednisolone dose needed to be reduced to below grams of prednisolone per day, and at the same time, reduction of the CRP below 10 grams per liter. So this is a composite measure that was used to decide if patients responded fully or had partial response. And with that composite measure, JAK inhibitors came up probably as the most promising agent, together with IL-6 inhibitors, had kind of similar response rate. JAK inhibitors at 12 months seem to have had more persistent complete response compared to other agents. Other therapies have really not shown much promise in this case series that was published from France. And just to show that these JAK inhibitors showed significant improvement in survival if patients remained on the treatment compared to other therapies from this group. We have copied our colleagues in France and done a similar study in the UK. This is currently under review. We had slightly fewer patients in the UK that were treated with targeted therapies. And this is the result of the work that we have collected, and the work was done by and large by Adam Al-Hakim, who is my long-suffering clinical fellow, who has devoted his life to VEXAS and collected this data from various centers across the UK that have been involved in treatment of patients. And again, looking at this picture, what is striking is that not many patients do remain on these targeted therapies for whole duration of 12 months. And that's largely either because they have died, or the treatment hasn't worked, or for the developing treatment complication. One drug that in particular has been associated with high treatment complications is anakinra, and that was noted very early on in discovery of syndrome, that these patients have developed this very paradoxical injection site reaction to anakinra. And the patients who have responded and done well on anakinra, they have, for example, remained on treatment for whole 12 months, but the treatment was really complicated by patients developing injection site reactions and unable to continue. Unlike the French cohort, our cohort, when we looked at our cohort, there was no treatment that was significantly associated with improved survival if patients stayed on treatment. And we also had a group of patients who were steroid alone. And again, that group of patients done as well as any other treatment, targeted therapy that we used at the time. An important point to make about treatments that we use is that infection complications are significant. And infection complications, even without treatment, are higher in patients with VEXAS syndrome. And this is because VEXAS itself leads to a degree of immune suppression, because the lymphocytes, the clone, the VEXAS mutation is toxic to lymphocytes. Many of these patients are neutropenic already. So infection susceptibility is already high, even without necessarily additional therapies. And this is, again, brilliant work that was done by French VEXAS consortium, which showed that infection rate increases as you progress with the disease, and cumulatively gets worse with the treatments. And actually is one of the leading causes of mortality in patients with VEXAS. So although we use these very powerful drugs to control the infection, to control the disease, the use of these drugs is really limited by the fact that many of these patients do go on to then develop significant infections, and maybe we are unable then to continue using some of these treatments on a long-term basis. And to conclude this part, this is again a consensus from the expert group on international expert panel that we had a meeting on quite a few months ago now. And this is now really the recommendation how we should again approach treatment of VEXAS. Again, this is with caveat, of course, that these recommendations are based on largely retrospective data, anecdotal evidence, without necessarily having any access to long-term cohort study or prospective trials. And as I suggested earlier on, it's at the start when the patients are presented with VEXAS, I think an initial assessment needs to be made whether or not some of these patients are candidates for hematopoietic stem cell transplant. The timing of the transplant is critical. Currently, it's not clear how long and we should be waiting for. Should we be waiting for the patients to develop profound anemia, or should they be transplanted earlier, given that there is a significant transplant-related mortality of 25%? But in my experience, I think what's important is that these patients are seen by transplant teams early, and full assessment is made early. So if there is a need to progress with a transplant, you don't necessarily have to wait to complete all the assessment, and all that can be done ahead of time. So you're ready to go ahead if you need to. The corticosteroids, vast majority of patients will require some degree of corticosteroid therapy. In my experience, again, if you can manage most of the symptoms on a corticosteroid that is less than 10 milligrams of prednisone a day, this is probably okay without necessarily then needing to introduce an additional agent, because the toxicity of the steroid at that dose is relatively small, and the risk of infection overall is probably less if you then combine some of the other targeted therapies that we talked about. So just to finalize, we don't really yet have ideal recommendation based on, as I say, prospective evidence. This is as best as we can come up with at this point in time. This is most quite likely to change as we learn more about VEXAS. And please don't forget about managing the other complications of VEXAS, such as thromboembolic complications, infections, and so on. So whether or not some of these patients need to be, for example, a long-term antibiotic prophylaxis is yet to be fully decided on. And I will finish there because we won't have some time for fun questions. Just to say that, as Sophie has mentioned, there is no precise genotype of VEXAS yet, but for sure this is likely to be expanding due to these other variants being discovered in non-canonical variants in UBA1. Best strategies yet to be, and we are urgently needing prospective trials to tell us how best to manage the condition. So I'll leave it there. I'll hand over to Sophie for her fun quiz.
Thank you. Yes, I will share my screen. Up. Can you see my screen? Can you see my screen?
Not
No,
yet
we can't
for
see.
me.
Not for you. Not yet.
No, not yet. We
So
don't see the
try
screen.
again.
We know that so people can ask questions during the time. We will have a Q&A
Now,
session.
can you see it? Can you
Yes,
see
we
it?
can see it.
Okay.
So let's try
So
because
in the last minutes, yeah, that's Sinisa. Let me. So I will propose a very quick true and false. So you will have only 10 seconds to vote for each question. So the first question is in the VEXAS syndrome. I want to check if you have listened well. What does V stands for? Does it stands for violet? So you have to choose a button, true or false. Does it stand for violet? So Camille will send the quiz and will tell me the best answer because I cannot see the answers. So Camille or Alexandre, I let you speak with me and tell me the results of the survey.
100% false.
Okay, so you were listening to us. So thank you. It was the beginning. So remember, it's an acronym. So now I will go to the second question. How many VEXAS patients are
We don't
diagnosed
see
to
in your
date in
screen.
2025?
I think, Sophie, you are not
You
in
don't see
a
my
full
screen?
screen. We see the screen, but it's in it's not in the full
Okay, I
full
will do
slide.
again, okay? So I will
Sure.
stop.
But the question is launched, and that's fine. There is some
Yeah.
response. People are very active, and the suggestion, I think,
So I cannot share my
60%.
screen anymore. I cannot
But
share my screen anymore. Camille, can you do something or no? Can you let me share my screen? Yeah, I can now.
I think the vote for this question was more than 1,000.
So
50%.
can you see my slide now? Can you see my slide?
Question. We see the question. So, yeah.
So should you stop the question? So, and you tell me how many people, what did they choose?
More than 1,000, 50% said more than 1,000 people
So
are
the
diagnosed.
public is good. So the good answer was more than 1,000. Can you see my slides?
Yes.
Okay, so the answer is to date in 2025, more than 1,000 are published. So the estimated prevalence is 1 on 4,000 men older than 50 years old from a BEC study. So now it's a new question. Can women display VEXAS? So choose an answer. Women can display VEXAS, yes or not. Women can display VEXAS, true or false. 10 seconds. So tell me the answers.
Large majority voted for true.
Okay, so the public is very good.
97%.
So I will give you the answer. So yes, they can. So just one very short slide. On this slide, you can see there's X monosomy. So we know now in the French cohort, we have about 5% of women, and there's an actual global mondial work ongoing with all the global VEXAS group, and we have collected already 14 women, and most of them have an X monosomy, explaining why they display the disease. So I will keep on. At what age should VEXAS be considered? Be aware of the question. Is it 23 years old, 38, 49, 63? The youngest VEXAS described to date. So please tell me when you see the selection from the public.
I think globally people say, I think 63 as the main age where you should consider VEXAS.
The mean age is 63, but I wanted you to be aware, even Alexander below, the pediatrician there, that 23 years old is the youngest VEXAS published with the classical VEXAS. I have to say, because there are one published case with a mutation in UBA1 in a child, but it's not a really clinical features of VEXAS. So this was a publication by Eduardo Martinez from Mexico. And the key message is that any adult with clinical VEXAS feature must be tested for UBA1, even though he's only 23 years old. So never forget this. So now,
that's an important point, Sophie, because you
yes,
answer a question raised by Katia Sokol, who has great presentation. What's the youngest age of a patient you've seen with VEXAS? So it means it's 23, and maybe some pediatrician will identify a VEXAS
yes,
someday.
exactly. So now, do vacuole have to be present to diagnose VEXAS? So be ready. So now you are all very aware of this. So vacuole are always present in VEXAS. So the question is, vacuole are always present in VEXAS? Yes or no? Please choose a button. And Alexandre, tell me the answer.
Yeah.
63% say false.
So public is quite good. So I wanted to have you, but I was not aware. So no, vacuole are not necessary to diagnose VEXAS. And in the French cohort, I can tell you we have 30% of confirmed genotyping VEXAS without vacuole. So genetic comes first. Can a VEXAS patient pass on the disease to his or her children? So this is the question. VEXAS can be passed on to the descendant. For example, you have a 45-year-old VEXAS man. He has children that are 20 years old. So do you think the children can display VEXAS? True or false?
I don't see the answers, but I think the 93% answered false.
So totally agree with you. So it's an acquired mutation. The A for VEXAS is from acquired on the X chromosome. So we believe that it's acquired and you cannot give it to your children. So I will go quickly. Which genetic test should be ordered to confirm VEXAS? So I want to check if you listen well to Sinisa. So select one. Is it Sanger? Is it Panel? Is it Wes? And yes, I'm a tricky woman. So I want to make a choice because we don't have a lot of time to discuss, but so what are the results?
80% for Sanger.
Excellent. So Sinisa explained perfectly. So I will just say that to date, the hotspots are in the exon 3 of UBA1, which is a very long gene. So we can perform Sanger, but there are some other mutations that Sinisa told you about. So if the Sanger sequencing of the exon 3 is negative, then you have to check something where else. And so in France, it depends on the city and laboratory. The Sanger exon 3 is inexpensive, fast, and quite profitable. Usually it's only a few days. But the alternative is to pan a myeloid panel or exome, or even, when we speak to David Beck, genome. Should we base our decision on the median globular volume? So be ready for the question. Is the VGM always increased in VEXAS? So true or false? The VGM is always increased in VEXAS. You should answer quickly. It's almost finished.
68% say false.
Okay, so actually, the answer is almost always, like 99.99. In very rare exception that I am aware of, there can be an incidental discovery on a pre-symptomatic patient because he had a myeloid panel, or it can be a patient with a concomitance of thalassemia, but it's very, very rare. So can we talk about VEXAS if the UBA1 mutation is negative? So this is not a question I will ask you because it would be too long, but it really depends. And Sinisa explained to you that, of course, you have to check what was the technique, and maybe it's a VEXAS-like patient because the hotspot is there, but there are other parts of the gene. So ask for a new technique, but I've already spoken of this. So this is almost my last question. Does having VEXAS always mean having myelodysplasia? So the question is, if you have VEXAS, does it mean you have myelodysplasia? True or false?
90% false.
Yeah, public is very good. So yeah. So it's no, and in our cohort, it's about 40% of myelodysplasia, and usually dysplasia of one lineage. And I just tell you that 23% have a monoclonal gammopathy. And this is, I think, my last question. Should all VEXAS patients have a myelogram or bone marrow aspiration? Bone marrow aspiration.
Yes, 95%.
So the answer is not totally known. So it's recommended in case of cytopenia, and some patients, they refuse to have a bone marrow aspiration. So you always have to look for myelodysplasia and other hemopathy. The last question is, are VEXAS patients at risk of infection? You should answer very quickly because Sinisa spoke about this. VEXAS patients are at risk of infection, yes or no?
Yes, indeed, 100%. So
yes, you are very good. You are the best, and it's the last question. So yes, yes, yes. But look at my smiley. It's a yes, but it's also a bad yes, because they are at risk of very big infection. We have the big French series on the left, and on the right is the NIH series showing all this. I will go quickly, but the French series showed you all the infection, especially Enterobacteria, Legionella, Mycobacterium atypic, pneumocystis, and COVID, so be aware of this. And this is a very interesting paper by the NIH showing a lot of Mycobacterium chelonae and avium. I lost a patient very recently with Mycobacterium chelonae, so I want you to remember this. And to finish, I show you this very nice picture. Maybe you can recognize Sara Bindoli and Sinisa SAVIC in this picture. Also, of course, Marcella Ferrada, David Beck, Arsène Mekignan, Peter Grison, etc. We were in Paris for the last first international workshop organized by the French network of rare disease, where Alexander Belot is the leader. And it was in Paris. And the next one, I just tell you, the advertisement is in New York in September 2025. And I thank you and all the French VEXAS cohort, and I thank you for your attention. And I will leave the screen.
For few questions, I think we are a bit late, but we have 3 questions. So quick question, quick answer. I will maybe start with the first one and let you, Sara, for with the next one. So
Yes.
Marina Margaret Macedo said, yes, excellent talk. On the UK series, the JAK used was baricitinib. Was there any particular reason for this? Why not using ruxolitinib?
Je pense 5 minutes parce que c'est ça.
Thank you for the question. Mainly, really, because that's the only one we were able to access. You know, the access to these drugs is restricted. Nothing is licensed currently for VEXAS syndrome, and depending where you are in the world, it depends really what you can access. I mean, people, you know, so there was a publication again from France where it compared different JAK inhibitors, and ruxolitinib seemed to come up on the top. I guess the difference being is that the ruxolitinib dosage varies. The baricitinib dosage that we used in these patients is 4 milligrams per kilogram. Sorry, 4 milligrams, which is a dose for rheumatoid arthritis. And maybe what these patients need is a higher dose of baricitinib than what we have used. And this really is all this stuff needs to be addressed in a prospective clinical trials. This is all guesswork so far.
Thank you. I don't see question in the chat box or in the question.
I think there is in the Q&A. I see another question from Philip Trescas. Can you speak to the relevance of neurological manifestation for the recognition of VEXAS? Are there something specific for VEXAS?
Yes, I can answer. And we have a paper in press from the French group, and we identified more than 30 patients with neurological manifestation. One of the most frequent is polyneuropathy, multineuropathy. I don't know how to say that in English. Well, it's peripheral polyneuropathy, and it's one of the most frequent. So yes, a neurological feature can be revealing VEXAS, and you will very soon be able to see that publication.
It is in press since yesterday, I think. But
yes.
On PubMed.
Yes,
and
exactly. Since Sunday, you are right.
And does UBA1 escape the inactivation of X chromosome in women?
So what we found in this international cohort on women is that most of the women, they really had a monosomy. So it means that they lost one X. So in this case, it explains the expression of the disease. But no, there's not inactivation, but just when they have two chromosomes, which is quite rare, and the other one is taking the lead and the disease doesn't express.
I have two quick questions. Okay, sorry.
Just to say, we have had a case of VEXAS syndrome in a female patient with two X chromosomes. So it's possible, rare, but we published that as well quite a couple of years ago. But you know, it was only one, and we didn't see random X inactivation. There was no skewing as far as the X inactivation is concerned. So that didn't necessarily account to why this patient had clinical features. But you know, for all the intents and purposes, she had a very canonical methionine 41 mutation and clinical manifestations that were in keeping with VEXAS.
Okay, just a question for Sophie. I have two patients actually. They had inflammatory fasciitis that sometimes can be. We know very well the infectious fasciitis. So this patient underwent to a lot of antibiotics, but they ameliorate with steroids. So I was wondering, how many patients have you seen or there are with fasciitis? I mean, this patient has a arm fasciitis that migrate from the left to the right arm. Have you seen this kind of clinical manifestation in VEXAS patients or not?
I didn't understand the word with what? With fasciitis?
Fasciitis, yes, inflammation of the fasciitis. Yes, sorry.
Sorry. So I showed in the speech, I showed a small picture, but it's rare. And a few of our colleagues are working on this muscular infiltrate, but it exists. And we don't have a lot of explanation. It can also be in the muscle here. It can be in all the muscles. So it's kind of strange. And it usually responds to the treatment.
Yeah, with steroids. In fact, this patient responded very well to high dose steroids. And yeah, and I have just a quick question for the treatment for Professor SAVIC. Sometimes we know that JAK inhibitors may worsen anemia, especially upadacitinib or filgotinib. I was wondering, it has been considered the use, for example, of anifrolumab, that is anti-interferon, for example. It makes sense to use it probably in VEXAS patients or not?
Sure, you know, you can target any cytokine in VEXAS response. Everything is elevated in VEXAS, so I really hard to know. I think that the way forward, I suspect, I mean, what's coming through more and more, that therapies that are targeting clone, so for example, azacitidine and similar might be probably the better way to deal with this. Some of the anti-inflammatory biological targeted anti-inflammatory treatments will be probably helpful for symptomatic relief, but none of these are associated with disease resolution. So you don't get huge improvement in bone marrow function or clone resolution, because there are again reports where after treating with anti-cytokine therapies or targeted biological treatments, level of abnormal, the mutation in the blood remains pretty much changed. So you're just suppressing the disease, but you're not actually making any difference in terms of the cure.
Thank you.
I think we need to stop the discussion. It was really a fascinating webinar. So thank you very much, Sinisa and Sophie, for this wonderful talk. So it is recorded, so anyone can look at this again. I just remind you that the meeting for the upcoming VEXAS symposium will take place in New York, 25-26 September of this year. And I thank you very much for coming and joining for the webinar. So it's very inspiring, and it's a revolution in the field of somatic mutations. That's so fascinating. Thank you very much, Sinisa.
Thank you very much to you.
Thank you, Sara.
Thank you. Thank you, Alexander. Thank you. Bye-bye. Thanks.